right, everyone, welcome. If you're a final year med student gearing up for exams, you are in exactly the right place. We are about to break down infective endocarditis into a super clear, high-yield blueprint that's going to get you completely exam ready. Let's jump right in. So, here's our game plan. We're going to tackle this in 5 logical parts. We'll start with a solid definition, then get into how the infection actually happens. We'll look at the usual suspects and the clues they leave behind, then nail down the diagnosis, and finally, cover treatment and prevention. It's a perfect roadmap for revision.
Okay, first things first, we have to build a strong foundation, and that means getting a rock-solid definition. You got to understand what we're actually talking about, and the 2 many ways it can show up, acute versus subacute. So what is infective endocarditis at its core? Well, it's not just some random heart infection. It's really specific. It's a microbial invasion of the heart's inner lining, the endocardium, and it especially loves to attack the valves. The key result of this invasion? The formation of these things called vegetations, which are basically these nasty little clumps of platelets, fibrin, and the microbes themselves, all stuck together. Now pay attention here, because this is a classic exam question, the difference between acute and subacute endocarditis. Think of it like this. Acute is like a violent home invasion. A really nasty, highly virulent bug like Staph aureus attacks a perfectly healthy valve. It's fast, it's destructive, and thankfully, it's less common. Subacute, on the other hand, is more like a sneaky squatter. A less aggressive bug, say Viridin streptococci, finds a valve that's already damaged and slowly sets up shop. It's a much slower, more insidious process, and it's actually the scenario we see most often.
So, moving on, let's trace the path of how this infection actually gets going. You know, understanding the how, the pathogenesis, isn't just for bonus points. It really is the key to making all the clinical signs and the diagnostic rules make perfect sense later on.
It really happens in 4 main steps. Step 1, something has to rough up the inner lining of the heart. This could be turbulent blood flow from a faulty valve, or even just the tip of an IV catheter. Step 2, the body's repair crew shows up and forms a sterile little clot of platelets and fibrin over the injury. We call this a non-bacterial thrombotic endocarditis, or NBTE. Step 3, bacteria get into the bloodstream, and this can happen from something as simple as brushing your teeth. These bacteria are just floating by, and they see that sterile clot as the perfect place to land and stick. And finally, step 4, they start to multiply, protected by more layers of fibrin, and that's how they build that infected vegetation, which can then break off and cause problems all over the body. Okay, so we know the how. Now let's talk about the who and the what. Who are the usual suspects causing this damage, and what clues will a patient present with? Getting this part right is absolutely crucial for building your differential diagnosis and starting the right treatment. This table right here, this is pure gold. Because the bug often depends on the patient's story. You have to lock in these associations for your exams. The #1 cause overall, Staph aureus. But if it's a native valve and someone from the community, you should be thinking Viridin streptococci. If they have a prosthetic valve, think coagulase-negative staph. An IV drug user, it's Staph aureus again, and you should always think about the tricuspid valve. And what if the blood cultures keep coming back negative? Well, think about whether they've had antibiotics recently, or think about those picky, hard-to-grow, hate-check organisms. So what does this look like in a patient? Well, I've got a great mnemonic for you to remember all the classic features. From Jane. F is for fever. That's the most common sign. R is for Roth spots in the retina. O is for Osler's nodes. Remember O for ouch, because they're painful. M is for murmur, specifically a new one or one that's changed. J is for Janeway lesions, which are painless. A is for anemia. N is for nail bed hemorrhages, also called splinter hemorrhages. And E is for emboli. Just remember from Jane, and you've got this. Look, having a hunch is great, but in medicine, and especially for your exams, you need to prove it. And for infective endocarditis, that means you have to know the gold standard inside and out, the modified Dew criteria. So, right, how do we go from, I think it might be endocarditis, to I am certain it's endocarditis? We need a system, a clear set of rules. And that's exactly what the modified Dew criteria gives us. It's basically a diagnostic scoring system. And the rule itself is actually pretty simple. It's like a little math problem. To make a definite diagnosis, you need one of 3 combinations. It's either 2 major criteria, or 1 major plus 3 minor criteria, or just 5 minor criteria. That's it. Memorize that simple formula first, and applying the actual criteria becomes so much easier. And here they are. The whole system rests on 2 major pillars. First, positive blood cultures showing a typical bug. Second,
evidence on an echocardiogram, like you actually see the vegetation, or you find a new leaky valve. The minor criteria are all the supporting clues: a predisposing condition, like a bad valve or IV drug use, fever, those vascular and immunologic signs from our From Jane mnemonic, and some supporting lab evidence. Knowing this table is non-negotiable for your exams.
All right, you've nailed the diagnosis. Now what? Let's get into the most practical part, how we actually fix this. We're going to talk about wiping out the infection and, just as importantly, how to stop it from ever coming back. Treatment is a marathon, not a sprint. It's all about long-course IV antibiotics that are targeted to this specific bug. This slide gives you the high-yield, first-line stuff you gotta know. For your standard MSSA, you're using nafcillin. For MRSA, it's vancomycin. Notice the timeline. We're talking 4 to 6 weeks of treatment. And here's the key difference to remember. For prosthetic valves, the treatment has to be more aggressive. We often add drugs like rifampin and gentamicin to break through that tough biofilm on the artificial valve. So how do we stop this from happening in the first place? Well, it really boils down to 2 main ideas. First, just plain old good sterile technique whenever you're doing an invasive procedure, especially placing central lines. And second, something called antibiotic prophylaxis. Now, this isn't for everybody, but for your high-risk patients, think people with prosthetic valves or who've had endocarditis before, we give them a dose of antibiotics before procedures that are known to stir up bacteria, like major dental work.
Okay, let's lock this all in. Here are your final rapid-fire revision points. The definition: it's a microbial invasion of heart valves causing vegetations. The pathway: injury to sterile clot to colonization to infected vegetation. The number 1 clinical sign you cannot miss: a new or worsened heart murmur. The diagnosis: that's the modified Duke criteria. Remember the 2 or 1 and 3 or 5 rule? And treatment: it's a long 4 to 6 week course of IV antibiotics, always tailored to the bug and the valve.
And I'll leave you with a final thought to chew on. With antibiotic resistance on the rise, dealing with culture-negative endocarditis is getting tougher and tougher. So how are we going to have to adapt? How will our diagnostic tools and our treatment strategies have to evolve over the next decade? It's a huge question for the future. Thanks for joining this explainer, and seriously, good luck on your exams.